Thank you very much for asking me to speak today. I am what I call a jobbing thoracic anaesthetist. It's the mainstay of my work, and I work with Meninda and Richard at the back there for, as I say, 18 years. And the difficult airway and the management of these cases that we've been talking about this morning are cases that stress most anaesthetists. I think it's fascinating to see the surgical side without the worry of maintaining airways and oxygenation. For those of you that are anaesthetists in the audience, most of what I'm going to say will be bread and butter to you. So I'm aiming this really at the cardiothoracic trainees amongst you to let you know what we get up to as anaesthetists and why we do what we do and when we get particularly stressed. So the aims of this talk really is to explain how we would facilitate you in your surgical assessment and management of these patients, because that's essentially what we're there for. And in order to do that, we need to obviously keep the patients asleep and maintain some form of gas exchange, which is often a real challenge. In order to facilitate what you need, the key, and we've touched on it already this morning, is communication. It's absolutely vital that we have a chat before we see these cases. These are often emergencies. They're not planned. They're not on your elective list. They've not been to pre-op assessment. They often come in late in the evening. You're struggling to get a slot in the emergency theatre. The patients are in extremis, and someone says, can you just slot this on the end of your list because we'll never get into the emergency theatre. And that's the way that we manage these patients. So communication is absolutely key. The pathology really will determine the airway management. The most difficult patients, I believe, are the Trachea Malaysia patients, because they're really coming for an assessment, and they're often not going to be improved by what we do. And in fact, as you might see later on in one of my cases, we can make them worse towards the end of surgery. The tracheal stenosis may be intrinsic or extrinsic. They provide their own challenges. Some of them may have a tracheal tumor, and how we anaesthetize them will depend on what their pathology is. With Trachea Malaysia, in order to be able to assess them, there are some schools of thought that say you really need the patient spontaneously breathing. Well, we're going to put a rigid bronchoscope down these patients, so you've got to have them anaesthetized. And to give an anaesthetic to a patient and have them spontaneously breathing can be done, but it is a challenge. And often what we will do is do an emergence type of anaesthetic where we'll put them off to sleep. We may paralyze them to put the rigid bronchoscope down and then allow them to wake up and breathe with ongoing intravenous anesthesia, so that you can actually look at the dynamics of the airway and make an assessment as to what your further management's going to be. In terms of the management of anesthesia, basically one of the cruxes that we'll always do, you'll always see is take the oxygen off, put an oxygen mask on and pre-oxygenate the patient. This is absolutely vital. As I say, these patients are often extremists. Their oxygenation is often threatened by secretions and chronic lung disease in any case. The FRC is what we're aiming to fill with oxygen. Now, if you had a normal, healthy, fit patient, perhaps like one of us in the room, and you rendered them apneic, you'd probably buy yourself about a minute and a half if their patient was breathing air, because the FRC is around about 2.5 litres. And if only 20% of that is filled with oxygen, 21% oxygen from air, you'll only have about 450 mils of oxygen available. And at normal oxygen consumption of about 250 mils a minute, you'll only have a couple of minutes. So by pre-oxygenating, your best scenario in a patient with normal lungs, if you fully pre-oxygenate and give them 2.5 litres of oxygen, you'll have 10 minutes. So timing is often absolutely crucial with these patients. We will pre-oxygenate them. We'll put an oxygen face mask on, and basically we consider them to be pre-oxygenated when their end-tidal oxygen is nearing 100%, and that can take some time, especially in these patients with the airway obstruction, because their minute ventilation is reduced. The other thing I'm often asked is, when would you do an inhalational induction versus an intravenous? The inhalational induction, the aim is, what we worry about is, if we put the patients off to sleep, are they going to completely obstruct? Are we going to have an obstructed airway that we can neither ventilate nor intubate? In practice, that's quite rare. The patients who stand the greatest risk of obstructing, and you would do an inhalational induction, tend to be the supraglottic tumours, which is not really, fortunately for me, my remit. Most of the tumours and airway problems that I see are subglottic, usually tracheal or in one of the main bronchi. And actually, by far the best way of having control is an intravenous induction. We do short-acting drugs so that we can get the patient awake, and that would be something like propofol, with a short-acting opiate, either alfentanil or remifentanil, which we may give by infusion. And the aim is to basically enable the surgeon to get airway control fairly quickly. Most of our muscle relaxants that we use will take a couple of minutes for full relaxation, but by using the short-acting opiates, we can usually allow you to access the airway within a minute or two. Again, the longer it takes, the more we have to manually ventilate the patient, the chances are we can inflate the stomach, and that again causes problems for the patient. There is also risks of aspiration. So we would normally do short-acting drugs aimed to get the patient in the position where you can get the bronchoscope in fairly quickly. The use of neuromuscular blockers, where a patient is acutely compromised, we could use a drug called suxamethonium. Most of you probably heard of it. That enables you to get access to the airway within about 30 seconds, really, 30 seconds to a minute. The problem with using the muscle relaxants is that obviously the patients can't breathe. So if you need to do some kind of dynamic assessment of the airway, we need to know about that in order to tailor the anaesthetic appropriately and use the correct neuromuscular blockers. Maintenance for these patients, in terms of keeping the patients asleep, is typically intravenous. You can actually use volatile agents on a breathing circuit, and I'll show you a method for doing that. The problem with doing that is the theatre pollution and keeping the surgeon awake with the anaesthetic gases coming back at him. So total intravenous is what we're after, and it generally gives pretty good conditions and allows for a fairly rapid emergence at the end. So these are some of the examples of how we would achieve gas exchange. Vital for us, again, to know exactly what piece of equipment you're going to be using in your bronchoscope. At Heartlands, we have 3-4 different types of bronchoscope with various different attachments for ventilation. And it's a disaster if we get to put the patient off to sleep and then find that the correct Sanders injector has been taken down to the emergency theatre or one of the other thoracic theatres. So it's absolutely vital, communication again, in making sure that we have the correct pieces of equipment. The top picture there is the old classic Sanders injector here. That connects onto the bronchoscope. It works via a venturi. I'm going to talk a little bit in a second or two about the advantages and disadvantages of these different methods. The bottom one here is the Storz bronchoscope. This does the same thing. It's a venturi, injects oxygen and entrains air into the airway. The alternative is to connect on an anaesthetic breathing system onto, again, this is a Storz scope, but I think the Negus is possibly one also you can attach on the anaesthetic circuit. So the choices of how we do it, as I say, it's low-frequency jet ventilation, and that's either a Sanders or a ManuJet. There are various different types of jet ventilator available, or to put on what I call intravenous intermittent positive pressure ventilation, IPPV, via the anaesthetic system. And there are advantages and disadvantages of each of those. So if you look first of all at the low-frequency jet ventilation, that would be the Sanders or the ManuJet. It's a pretty simple piece of kit, to be honest with you, but in the wrong hands it can be lethal. It does give the surgeon a clear, unobstructed view. There's no anaesthetic bits of kit in the way. There's no endotracheal tube in the way. And as Meninda said, it gives you very clear access to then put down your fibre optic scope alongside it. There are a list of disadvantages. Barotrauma is a real potential problem. Whenever we jet the patients, we need to ensure that we have a route out for the air. We're putting the oxygen in and the air in under reasonably high pressure. And if you don't allow and make sure that you have an exit route for that air, you get stacking and you get an increased intrapositive pressure, and you can cause a pneumothorax, tension pneumothorax in these patients. And that's particularly important when you're putting fibre optic scopes down the rigid bronchoscope, because it's quite a narrow access channel that you have, and you need to make sure that you allow route of exit. From our point of view as an anaesthetist, it's slightly alien to us because we're used to having tubes in with lots of monitoring of gases and pressures and volumes. And actual fact, with this, you have no airway pressure monitoring. You have no measure of the adequacy of your ventilation, which we would normally measure by how much carbon dioxide the patient's breathing out. And you have a very variable tidal volume. And that tidal volume will vary with the patient's compliance of their chest wall, with what's going on with your instruments within the airway, and with the state of muscle relaxation that we've given. You also have no control over the FiO2, the inspired oxygen concentration. When we're using the anaesthetic circuit, we can dial up how much oxygen we're giving. We have no control with this. Typically, the Sanders injector with air will give around about 80 to 90% oxygen. There is a risk of fire with high flow oxygen. In practice, I have never seen an issue with this, and I think it's probably more theoretical than practical problem. So looking at when we put a breathing system onto the bronchoscope instead and save some of those problems and make us happy because we can monitor it, well, you get a clear unobstructed view. You potentially can measure the FiO2, end tidal carbon dioxide and tidal volume. You potentially can monitor, and I say potentially for a reason that I'll come to in a minute. And for the patients who are sick, who maybe come from the intensive care unit, who have a PEEP requirement, you potentially can put on PEEP. The disadvantages are obviously you need an anaesthetic machine, it's bulky, it sometimes gets in your way, there's a risk of pollution if you're going to use volatile agents, and the biggest problem with it, which is why I said potentially to everything on the left, is the risk of giving inadequate tidal volumes and getting your monitoring accurate because you often have a big leak. The bronchoscopes may have bungs on the end to allow the instrument through. In practice, our surgeons like to take all those bungs off and leave the airway open so that they've got access to put the scopes in, and you have a big leak. It's absolutely vital that there's good communication, and probably what we do as experienced thoracic anaesthetists is eyeball the chest movement, and actually that's what you do in paediatric anaesthesia. You set your ventilators and your pressures so you actually see the chest moving, and that's in most cases where we're using the jet ventilation, your best way of assessing adequacy of oxygenation. And we say, we're not ventilating at the moment if the chest isn't moving, and we have to speak to the surgeon, ask them to move their instruments. It may be that the tumour's in the way, and we just have to bite the bullet. In terms of oxygenation, obviously the pulse oximeter has revolutionised this type of surgery. The problem with the pulse oximeter, though, is that it has, even with the modern machines, at least a 20-second lag time on it. So when our monitor says 96%, 94%, 93%, the saturation is probably already less than 90%. So our policy is we normally ventilate and allow the surgeon to do what he needs to do down to a saturation of about 94, which is probably really about 88. And at that point, we say, no, we need to ventilate. And it has to be a two-way communication. Sometimes, if it's a crucial time where tumours are being removed and or foreign bodies are being removed, we have to just bite the bullet and allow the saturations to go because it's a critical moment for the surgeon. But again, it's a matter of communication. The surgeons have done their, you've done your piece, the stents are in, the tumours are removed. Our next tricky bit is the emergence of the patient. We tend to have a number of options. We can just hold a face mask and let the patient wake up. We could put a laryngeal mask in, or we could intubate the patient. And you can't always do each of these. Sometimes we need to put an endotracheal tube in if there's ongoing potential for bleeding while we're waking the patient up. And that's the one time where I would tend to put a tube down at the end if I can, where you know that you've got some ongoing secretions and bleeding and you'll need access to make sure that the airway's clear. So you basically wake the patient up with the tube in. Laryngeal mask is, again, it's only been around for probably 20 years now, but again, it's revolutionized these. It'll give you an airway, but it won't give you any access to the airway. And a face mask is usually where we've been doing patients who are spontaneously breathing deep on anesthesia. You can just put a face mask on and allow them to wake up. Crucial at this point when we're doing Emergence that all the airway kit stays in theatre and the surgeon is easily available, because very occasionally we need to quickly put a bronchoscope back down, resuction, and remove foreign bodies. This is just one case as an example. This highlights the problems with the obese patients, really. This was a patient, thank you to Melinda for these slides, who was 145 kilos, who had had a thymectomy done for a malignant thymoma some years previously. After her, so you can see what the sternal wires are from her thymectomy. After her surgery, and the surgery wasn't done at our hospital, she suffered with what was diagnosed as Trachea Malaysia. And you can see on the slide here, she had a, get it the right way around, she had a tracheal stent placed. She had this done on several occasions, and the stent was removed and put back and taken out and put back. And she presented to our hospital in January of this year with ongoing stridor and airway obstruction. And you can see here the stent actually is in place, but occluding her left main bronchus. That's it there. So the question was what to do. Well, the difficulty for us as anaesthetists, she's 145 kilos, she's short-necked, she's already hypoxic, she's got stridor. She had an intravenous induction, and again, you know, trying to do a gas induction in a 145 kilo patient is asking for trouble. She had an intravenous induction, the stent was pulled back, and she was extubated. The bronchoscope was taken out, and she suffered then with ongoing stridor. So the question is, well, we pulled the stent back, the airway was clear. When you try to wake her up at the end, she's again got considerable breathing difficulties and stridor. So this was a case where we had to ask the surgeon to come back in quickly, to put the bronchoscope down to have another look. And the stent had slipped back down. So the decision was made to take the stent out. She again suffered with stridor and breathing difficulties. Trachea Malaysia is an incredibly difficult condition to manage perioperatively. The decision was made, therefore, to put her on the intensive care unit with an endotracheal tube in and to electively ventilate her and wake her up in a controlled fashion. With the Trachea Malaysia patients, basically, the harder they breathe and the greater the negative inspiratory pressure they produce, the more they obstruct. And this is what patients tend to do when they wake up. They're panicking, they're trying to cough. So you need a controlled extubation where you can talk to the patient and say, you have to control your breathing and breathe slowly, and then you can take the tube out. I just highlight this X-ray here to say that all that causes trouble is not always related to the surgical problem that's being dealt with. And this was the X-ray of the lady the next morning when Mr. Calcutt went to see her on the intensive care unit. And obviously everyone thinks, oh, you know, she's obstructed her left main bronchus again and she's in trouble. But actually, it's the old anaesthetic chestnut, this, and that the endotracheal tube was actually in the right main bronchus. So it just illustrates that, you know, it's quite easy to get focused in on what is your original surgical problem, but actually other things can cause the problem, and sometimes it might even be us. So when her tube was pulled back a bit, she then ventilated easily. And the final ones, you may have seen these pictures. This is an airway tumor that was presented fairly recently, just over the right main bronchus, which was lasered. This was the lasering afterwards. And this is the sort of case where I'm able to put an endotracheal tube in at the end. I've got ongoing bleeding. I know the airway's secure, but if I wake him up with an endotracheal tube in, I can make sure that his airway's clear right until he's awake. And actually, this gentleman did very well. The difficulty is when you've got the stent higher up. As you can't always put an endotracheal tube in if you've got a stent just below the cords. So in those cases, we'd have to do a laryngeal mask. And actually, what we tend to do is leave the bronchoscope in as late as possible, then put the laryngeal mask in, allow the patients to breathe. Okay, thank you very much. That's